Good morning. Next lecture, it is a very important lecture, challenging cases in interventional pediatric bronchoscopy. I would like to invite Dr. Sarabon Tahura from Bangladesh. He's a pediatric interventional pulmonologist and associate professor, Department of Pediatric Respiratory Medicine in Dhaka.
Very good morning, and planet audience. First of all, I'd like to give thanks, my sincere gratitude to Dr. Niranjan, the president and of this conference, and his team for their kind invitation. It's my great pleasure and honor to be here in front of you. The next couple of minutes, I'm going to present the challenges cases in interventional pediatric bronchoscopy. Planet audience, look at the picture. The first one, the ship is running in a very calm and quite favorable condition in the sea. Have the appropriate sail is the adult bronchoscopy. And just look at the second picture. We are struggling in a very, very obstacles and adverse situation of the appropriate size bronchoscope, accessories, and manpower, resource, everything. And is the condition of the pediatric bronchoscopy. When you think about the pediatric bronchoscopy, the first what comes in mind, that is, is for the exclusion of the airway anomaly or taking bronchoalveolar lavage. If you think about it, the intervention, definitely for the last many decades, people think the one thing, the removal of the foreign body. So just observe the two foreign body removal cases. The first one is the round shaped peanut. So usually here everybody use such type of accessories, that is the basket, to remove it out. And in the next, it is the sharp and very sharp and very thin structure is the hijab pin. Usually we use the rat tooth forceps to remove it out. Both video looks it looks very easy to remove the foreign body. But look at the 15 years old boy's story. He had history of aspiration of LED bulb of a pencil torch light 1 and 7 months back, and just observe the situation. When I go into the airway, I found there is literally a breeze, granulation tissue breeze over the foreign body. So it's not possible to remove it out with the removal of this granulation tissue. And it's the story of an 8-year-old girl who had history of accidental aspiration of tablet. It was the flucloxacillin tablet while having orally 5 days back. Just see, the foreign body was badly stuck at the lumen, and it's just just see, when I introduced the accessories, that is the basket and the forceps, it was too fragile to hold it with that type of accessories. Actually, the children can give the history of the foreign body aspiration, and it's our ongoing work that on the 13 children, and the study revealed that near about 60% the patient or the younger than 2 years is actually this patient and failed to give any history, and only 18% had a definite history of foreign body aspiration. And there are lots of myth and misconception among the people, and that actually unwitnessed non-radiopaque foreign body aspiration may remain subtle and give rise to the local inflammation, edema, cellular infiltration, granulation tissue, and all these actually increase the therapeutic changes. And in that cases, you need to do some advanced interventions like the fire and ice. So what is the fire? Is the argon plasma coagulation? Is the non-contact mode of monopolar electrical coagulation, where argon gas is used as the conductive media, and the indication of the APC is to ablate the malignant airway tumors, counter hemoptysis, pneumophalangeal granulation tissue, and a variety of benign disorders. And what is ice? Actually, is the cryotherapy, and cryo means it's ancient Greek word, means the ice, chill and frost. Actually, it is the evolving technique of rapid freezing and thawing to manipulate the tissue by deliver a device named cryoprops. So indication in children are for removal of the foreign body, removal of the difficult mucus plaque, large clot, and tumor granulation tissue, and relieving the stricture of the TBS stenosis. And transbronchial and endobronchial biopsy is definitely a good work. And all this intervention, when you think that you want to do in a pediatric patient, so many obstacles come in front of you. That is do you have the appropriate size, all the accessories or the device in your hands or not? But fortunately, over last few years, now the pediatric scope having a smaller outer diameter with a sufficient size working channel and small size endobronchial ultrasound and forceps and cryoprobes are available in market. And all these actually allows diagnostic and therapeutic procedure to be done. So just come to that case, I found the granulation tissue over the foreign body, and just see, I just apply the APC over the granulation tissue breeze, and after applying the removal of the granulation tissue, just see, I think you don't forget that the foreign body was the LED valve of a pencil torch battery. And after removal of the foreign body, I just use the rat tooth forceps. Usually I do use to remove the foreign body. So at a glance, and just see, after the whole procedure, it maintained the patency of the normal airway. So when you use the APC, just keep in mind that the power must be at the 30 watts and argon gas flow less than 1 liter per minute, and probe is must position several centimeters beyond the bronchoscope tip for the safety, and the probe is placed within the 1 centimeter of the target lesion, and care must be used to ensure that the catheter doesn't come into the direct contact with the target tissue. So it was the second case that tablet, badly stuck tablet in the right main bronchus, where I used, that was too fragile to hold with any type of accessories, that is the basket or the forceps. But just see, there is the forceps, and that actually I used the cryoprobe to remove it out, and with the piecemeal maneuver, just see that I removed this foreign body totally out. So what is the physics behind the cryotherapy? When a liquid gas under pressure come through a small orifice, it causing the conversion to the gaseous liquid form to gaseous form, they just release actually a dramatic fall of the temperature, and that actually captured at the cryo tip. And just see the procedure. So come to very interesting cases is a story of a 13-month-old child who developed the non-resolving cough for last 7 months, and by this time he was treated with the several cough syrups, nebulized salbutamol, nebulized steroid and oral antibiotics without any significant improvement. And one thing, a mother didn't give any history of any choking attack, but definitely there is the hyperinflated left lung. So when I go into the airway, just see what was there. When I go into the proceed, there is nothing in the trachea. When I go into the right main bronchus, just see something is there, but not the foreign body. When I went beyond that structure, I first found the foreign body actually, and what was that? And I removed it out with the rat tooth forceps. But after removal of the foreign body, just see after removal of the it removed with the rat tooth forceps successfully. When I went again to check what was there actually, just see it is the foreign body. Mother did not give any history of the foreign body. And when I went again, I found there is the granulation tissue actually. And with the electrocautery snare, I snared it out. And what was the foreign body? Actually, the foreign body was the outer shell of a peanut, and it is the tumor-like granulation tissue. And it is the whole procedure. It is the electrocautery snare. Like the debulking of a mass, I just snare it out and just see the before and after X-ray. So it is the another interesting case of a 11 years old boy who developed non-resolving pneumonia, chest pain for last 4 months, and X-ray chest revealed that the foreign body in the right lower lobe bronchus. So just we know that the foreign body is there, and it is at lodged at the right lower lobe bronchus. When I go into the right lower lobe, I don't find any foreign body. Just see what is there. Just see, it is something coming out with the respiration. It's like the mass. And but we know that the foreign body behind it's like the foreign body is buried behind the granulation tissue. So here I applied the APC, argon plasma coagulation, to remove that granulation tissue from the surrounding mucosa. And after removal, the granulation tissue, I used the cryoprobe to remove it out. Just see. I applied the cryoprobe for removal it out, and after removal of the granulation tissue for the first time, I noticed the foreign body, but I don't know what is this, what kind of foreign body is there. And with the rat tooth forceps, I remove it out with the same manner. So actually, what was that? The foreign body was the 1.5 centimeter long cone-shaped plastic metal. Is the one end of the ballpoint pen. Is that part. So it's all about the foreign body. When foreign body removal is not a simple foreign body removal, it needed so many advanced procedure, that is the electrocautery snare, APC, cryo, everything. So just look at that X-ray. It is the X-ray of a 4-year-old girl who transferred from the other hospital to our institute for the persistent collapse of the right lung. Initially, he was treated as the pneumonia. And with that X-ray, actually, when I go into the airway, I found that there is something in just above the carina and extending up to the right bronchus, and it literally looks like the peanut. Just see, it looks like the peanut, and I thought that yes, it may be the peanut, and I applied the forceps, and I failed to hold it, and at time it started bleeding, and for the first time I found that it's not the foreign body, it's the mass. And when I found that it is a mass, I applied the electrocautery snare to snare it out. So just see, the window is very open, so it was possible to remove at the whole mass at a time. So it's the pre-procedure and the post-procedure X-ray. What was that? Actually, it was the aspergilloma. So it is the another very, very interesting case of a 11-month-old girl who developed sudden onset stridor. And initially he was treated as a group without any improvement. Just see the X-ray. Bronchoscopic view in the trachea, in the lower part of the trachea. Just see what is that. Actually, the child was admitted in PICU and was intubated for 10 days, was 1 week, and was on mechanical ventilator for the dengue fever and pulmonary hemorrhage. And after the weaning of the tube, the child developed a stridor 20 days after the weaning of the ET tube. So it is the post-intubation tracheal stenosis grade 3. So is the critical grading is the grade 3 need to do the interventions. But the challenge is there. The child is 11-year-old, but the weight is only 7.5 kg. So I have the 2.8 outer diameter bronchoscope, but having the 1.2 millimeter working channel. But that size CRE balloon or the forgetty balloon, that is actually need to do that intervention is not present. Actually, 0.8 millimeter balloon or forgetty balloon is it's not available in Bangladesh. So, but it is critically stenosed the main trachea. So need to do very first. So what I have done, I just introduced the CRE balloon and under the fluoroscopy guidance with the guide wire. Just see, I introduced the CRE balloon and position at the site of the stenotic part, and just see here, it is inserted and inflated. After the balloon dilation, just see, it is the before, that was the critically stenosis, and after that, this is the same type of case, but the age of the child was 6 years. So, but the stenosis at the subglottic region. And so I was able to introduce the electrocautery knife. Just see the electrocautery knife. So, learned audience, a picture is worth 1,000 words, and bronchoscopy is the visual examination of the airway. You need to do bronchoscopy. The age is not here the matter, and all procedure is actually feasible for the any age or even in the tiny children. So, it's my last case, and just have a look. Is the case of a button on of a shirt of a 6-year-old girl who developed the non-resolving cough for last 3 months, and but no, he didn't give any history of foreign body aspiration, but X-ray revealed the foreign body is there. And when I go into the airway, I found there is the very tough structure over the foreign body, that is the granulation tissue, but this granulation tissue is very huge. It looks and so tough. So I applied the electrocautery knife here to cut it out. Just observe the way how I just cut the very tough granulation tissue. Actually, the foreign body was buried behind the granulation tissue base, and after the several attempts, finally, it was possible to cut. And the foreign body was found in the bronchus intermedius, and it is the metallic part of a pattern of a shirt, and I remove it out with the rat tooth forceps. And after removal of the foreign body, I went into the airway for check, but something is there. Is the looks like the diamond, and with the basket, I removed this foreign body again. And actually, it was not the real diamond; it was the fake diamond. Whatever it is it was the stone topping of the button. But just look at that side at the cutting edge. If I just left at that condition, it will give rise the stricture or the stenosis of that part. So I applied the APC there to for the ablation for the remnant of the granulation tissue. And after the whole procedure, just see, it is the pre-procedure, and after the post-procedure, it just maintain the whole patency. So, learned audience, flexible bronchoscope assisted interventions in a pediatric population is feasible, safe, and need to do. So I am working into a center. It is my government hospital, the largest pediatric hospital in Bangladesh Shishu Hospital, and it's my team, and I also work in a corporate setup, and all these, and like children, the snap was taken at the first follow-up after doing the bronchoscopy, the intervention. So, learned audience, thanks for your patient hearing.
Thank you so much, Dr. Tahura. The floor is now open for questions.
Thank you very much. I'm Dr. Chandraseela, pediatric pulmonologist here. It's very interesting. It's very difficult to intervention small children through flexible bronchoscopy. So you did marvelous job. So I just want to ask, one of the important limiting factors is small children, it's difficult to pass a larger diameter scope. So what are the scopes that you're using, and what is the minimum age that you did this type of intervention smallest children?
Okay, thank you. A very important question. And at present in the market, the available size bronchoscope is the 4.2 outer diameter, having the 2 millimeter working channel, and another is the 2.8. They are from the Olympus, but nowadays some single-use bronchoscope is available that is ranging from the 2.7 to 5.2, but the problem is there, the working channel is very narrow. So, yes, 2.2 outer diameter bronchoscope is available also from the Olympus, but they don't have any working channel. They only for the evaluation of the tiny neonate, not for the intervention. And but 2.8 size is appropriate. I have introduced that size bronchoscope in the 8 days old children also.
Yeah, that's great. The last questions. Have you encountered any complications while doing this procedure, especially in small children?
Sorry, I
Any,
didn't get it.
any type of complications have you encountered while doing this
Okay.
procedure in small children?
Okay, the actually our debate is still ongoing that what is the safest way is the rigid or the flexible bronchoscope. Who love to do the rigid bronchoscope always says that it's not very safe for the and something like that. But my experience. Yes, sometimes causing the transient hypoxia, but that you need to withdraw for sometimes, and after increase the saturation you can introduce. So it's the very common complication, and usually to secure my airway of the patient, I usually use the LMA. And LMA that give the advantage that over the ET tube, that is, I can easily see the whole of the trachea, and I can just with the catheter mount, I can connect it with the anesthesia machine, with the oxygen supply, everything. So with the LMA and introduce a bronchoscope is really feasible, very useful, and without any complication. As per my experience. Sometimes bleeding may occur. It is not for the scope related complication.
Thank you, Dr. Tahura. So the instruments that you've been using, we saw the rat tooth and the basket that you've been using. Anything else that was useful for you when removing foreign bodies? I just went, a couple of years back, I went for a workshop in Singapore. They had all sorts of stuff. I'm sure you don't have any of those. They showed like a magnet forceps to extract metal foreign bodies. Do you have any experience with any of that?
Sometimes it works well for the sharp end metallic foreign body, that is the hijab pin. Hijab pin, a scarf pin, and having the sharp end, and if you introduce, if you try to remove it with any kind of forceps, and if the sharp end is beyond your forceps, then it caused the trauma to the surrounding structure. So here, easy, yes, now in market, the forceps with the magnet is available, and it is applicable for when the foreign body is the metallic in origin. And there are so many forceps, so many baskets. There is the hexagonal basket, GOT basket, with tip basket. But you need to, it is the individualized and tailored according to your need.
Thank you.
I just have to make a comment. Actually, I'm Amila, I'm one of the adult pulmonologist, but I'd like to congratulate you. And it's a brilliant work. We know how difficult to do the maneuvers, even in adults, with this flexible bronchoscope, and well done, and congratulates. We are so proud of you.
Thank you. Thanks for the kind words.
Thank you so much. So we'll have to close the session now. Thank you so much for your lecture, Dr. Tahura. We have a small token of appreciation for you.
Thank you, madam, for sharing your invaluable experience in the field.